Oh, Dr. Stiles, nice to see you.
Hi, Linda.
All right, I think you can hear me okay. Okay, I'm going to have the pleasure of introducing Dr. Dennis Stiles. He's a native of Amherst, Massachusetts, but has called Upper Montgomery County his home since 1986, so it makes you almost a native, I think. Dr. Stiles is currently a member of the American Dental Association, the American Academy of Cosmetic Dentistry, the American Academy of Dental Sleep Medicine, the Maryland Sleep Society, and the American Academy of Implant Dentistry, and has received fellowship in the American College of Dentists, the International College of Dentists, and the Academy of General Dentistry. In 2017, he achieved diplomat status in the American Board of Dental Sleep Medicine. Dr. Stiles has served as president of the American Prosthodontic Society in 2006 and currently is serving as the president of the American Prosthodontic Foundation. In 2009, he was appointed to the Dean's Faculty at the University of Maryland School of Dentistry, where he continues to offer instruction on occlusion, comprehensive care, and sleep medicine to AEGD residents. In 2019, Dr. Stiles was elected to serve a second three-year term as a board member of the L.D. Pankias Institute located in Key Biscayne, Florida. He is currently serving on the board of the Maryland Sleep Society. Welcome, Dr. Stiles.
Thank you, Linda. I'm glad to be here. And what a great afternoon, great day. We are lucky to have the opportunity to be together, and I know it's a virtual way to gather, but I think we've figured it out, and I hope that I can cap off this day and bring you in for a landing, I suppose, to the end of day one, and look forward to our morning together tomorrow. I think there's been a common theme for today that that's kind of resonated for me, and that is titration. I think if we look at all that we do in our different disciplines, that's probably the top of the hill as far as the way we approach our care and how we figure out what's most appropriate for our patients and finding solutions and being advocates, just like our Dr. Mulcahy just mentioned. I love the concept of advocacy. And there we go. So we all know that we've had to make a big leap from last year to this year. And, you know, the things that I think most about in that gap between where the sun is coming up over the horizon there is, I think a lot about courage. And I have to just earmark, you know, my gratitude for the courage that this organization, the Maryland Sleep Society, has had to bring us together today for this virtual conference. And I just want to, you know, thank Dr. John Brown for all of his courage, really, and leadership, because he's really been a great shepherd through this time for our nonprofit. The Maryland Sleep Society, in my estimation, is really focused and here to stay, and has so many great qualities that you know make it a really compelling organization to be part of. I'm always glad to disclose that I have no conflicts of interest, and certainly want to make sure that we all are paying attention to our accreditation requirements. I hope today that you know, as we come in for our landing together and finish up our day, that my contribution to this conversation from a dental perspective, as one of the team members, you know, as we look at our, you know, goals relating to patient care, would be to really help facilitate the conversation around communication when we look at dentistry helping with oral appliance therapy. Understanding, you know, what titration really means to us and how we do that, and how we can help be part of that success element, and offering an alternative to CPAP, of course. And really, you know, I'd like to show you in video presentation, just a short minute away here, to give you an idea of how we start our titration process from a clinical perspective. I'm a clinician at heart. I do teach at the dental school, and and I enjoy serving on this nonprofit to help facilitate good conversations between all the different disciplines. And finally, just looking ahead to our future. I want to thank the team at Maryland. I consider our team Dr. Larry Cohen, Dr. Monsi Diaz, and what we're talking about is the dental side of offering sleep medicine to the curriculum of dental students, bringing sleep medicine to the the forefront of our clinical experience with our patients, so that we're screening well and teaching students how to understand some of the dynamics and symptoms that are associated with some of our patients that might be helping the patient get referred to a proper place for care. Monsi, I might also point out, has been a leader in sleep medicine, working with the hospital and the medical center at Maryland. She, to me, is one of my heroes in sleep medicine, because she offers a multidisciplinary conference on Wednesday mornings that now is virtual. A lot of learning there, and a lot of good conversations from different disciplines. And once a year, she offers a sleep boot camp, which I find to be extremely valuable, and really always look forward to it. The mission of the Maryland Sleep Society really, at its center, places the patient at its as its primary mission. And when we can bring healthy sleep strategies to our patients, offer appropriate means of treatment that fit the profile of the patient, and be their advocates, that's a win-win in my estimation. And the partnership is, when I think about partnership, we partner with our patients to help facilitate well-being, but we also have a partnership between all of us, all the people that are involved with sleep medicine. Sometimes I think about the Maryland Sleep Society, I think about the United Nations. I think we're all really on one ship, and we're aiming to really help patients. And we've got so many different disciplines that represent the helpers, so to speak. And I can't think of a nonprofit that I've been part of that really represents a significance like this, and drives a direction toward helping each other to be successful with our patients. So I'm really glad to be, and honored to be part of this conversation today, and also be part of this nonprofit in a way that I serve as one of the board members. So we all know a lot about titration, and certainly there are many avenues that we take. Before we get started with my conversation around titration applying to the oral sleep appliance, let me just create some definition. There's a lot of different terms for this particular avenue, this treatment modality. OAT would be oral appliance therapy. MAD would be mandibular advancement device, and MRA would be mandibular repositioning appliance. So there's a lot of different terminology for the same thing, but at the end of the day, we're really fabricating a device that acts to help reposition the mandible forward and pull the tongue forward. I know that we had a good conversation about the hypoglossal nerve stimulating device. At the end of the day, we're trying to get the tongue out of the way. So what I'd like to do is just walk you through the first step. As a clinician, most often I'm taking digital scans of patients, and then making the device, sending a prescription to a laboratory that makes the device. I've received, in my protocol, I'm receiving a prescription from a sleep physician and the sleep physician's asking me to make the mandibular advancement device for the patient, I'm not always the dentist for the patients that come in to see me. Sometimes they have their own primary care dentist, but I serve to help facilitate the directive of the sleep physician. Typically, once I've met the patient, had a consultation, received the appropriate information, including the prescription, I do review the sleep study with them, and it's always important for me to have a look at that before I see the patient. And then we move forward with an examination. I do a thorough examination just to make sure all the dental the dental diagnosis is complete, so that we aren't, if we have to send them back to their primary care dentist for some dentistry before we make the appliance, we always find that to be a very important piece of the equation. We don't want to make an appliance and then have to see a patient have some changes made prosthetically and then have to come back and readjust the appliance. So when we do this, we actually just typically start with the scan of their dentition, and then we measure. So we're measuring initially the way that the patient bites together, so we can see where their upper and lower jaw relate. We want to get a baseline of just normal bite. So this little device we're using here is called a George gauge. This allows us to get a normal bite measurement, and it's calibrated on the front of the gauge as I'm pointing to it right there. Once I calibrate the normal bite position, and then I ask the patient to move as far forward as they can. So that's a maximum protrusive position. So they're moving their jaw forward, which also pulls the tongue forward, and that position is recorded. After we record that, then we determine the proper position that we want to have the appliances being fabricated set to. So we set it to about 65 to 70% of maximum protrusive. Based on what we've experienced, we don't want to over protrude a patient because that can create some painful problems, and I'll talk about the temporomandibular joint in a minute. But basically, we want to start them at a very reasonable place that they can tolerate, and then slowly move them forward. So right now I'm taking a record of that position with some special recording material. The patient bites together, holds that position at the set position that we've determined is where we want to begin the titration. So even before we insert the appliance and teach the patient how to use it, we already have pre-established a beginning baseline position that we want to begin our titration from. And then after we take that record, we then we'll do a scan. The scan records the upper and lower teeth. We use that, we disassemble that from the George gauge, which is the gauge we use to actually, as you saw, measure the different positions. We take the scanner, which takes very high graphic video of the teeth, so that we can actually make a model sent to the laboratory fabricates the device. This has changed a lot of our workflow protocols in dentistry. By doing this digitally, we don't have to take impressions and make stone models anymore. You can actually just scan, and then the digital scan is printed into models, which is really a pretty it's given us a lot more flexibility and accuracy. And maybe some of you who have been to the dentist have experienced digital scanning. So now what we're doing is scanning the bite position that we've established, which is going to be, again, the baseline position that we start our titration. Once we scan both sides, basically the bite record, the position of the bite is established, and then as you'll see in a minute, you'll see the actual scan completed, and then you'll see the position of the lower jaw being a little bit more forward than the upper. And again, that's our starting point. That's where we're going to see the beginning point for our appliance. There you go. You got a little bird's eye view of our practice and seeing how that works. And sometimes it's I get curious about all the things that my medical providers are doing, and I hope that this gives you a little sense of what we do. So as we look at, this titration process, we certainly understand that we're going to be delivering a device. The lower jaw is going to be pulled forward, usually starting the titration around 50 to 60% of maximum protrusion position. And this diagram just shows you a little bit more about what we were just doing. There are probably well over 200 to 300 mandibular advancement devices out there, different devices that have been invented and by smarter dentists than I am. But I think that what we have to really do is figure out what works for us and what works for our patients. So here's an example of 3 appliances that I like to use. One has a strap in the middle that holds the patient forward, but gives them a little bit of freedom to move around. One has a wing profile, and you can open and close, and not have as much restriction. And then the one on the far left with the blue strap is an upper and lower appliance that's made out of a medical grade nylon. And that uniquely has a feature where if someone is a mouth breather and they don't breathe very well through their nose, the air will be pushed through that appliance to the back of the nasopharynx area. It's really interesting. Actually, that's the one I wear when I wear an appliance. I have mild to moderate sleep apnea, by the way. Anytime we get into goals in therapy, the one thing I'm starting to think about, again, what's the most appropriate way to manage a patient? I'm going to take a good history, and I'm going to learn a little bit about their temporomandibular joint. I'm going to learn about what has led them to being a sleep patient. Obviously, they've been diagnosed by a physician, and I'm in the position to be a helper. In many ways, sometimes this isn't always a clear message, but the dentist, as part of the the sleep medicine team, is really the DME provider for a dental appliance. And we're here to figure out what's the best fit for the patient, what position we want to put the patient, how we're going to titrate. But we still need help. We need our sleep physicians and our sleep technologists to help us figure out what the best position therapeutically is going to be and how that patient's going to respond. I certainly want to, just getting back to the temporomandibular joint, I just want to make sure that I'm not making the situation worse. Sometimes that temporomandibular joint patient who's experiencing pain is actually a sleep patient who's not been diagnosed, and we find that in a lot of our screening protocols now with our patients, when we start to understand bruxism and we look at some of the signs and symptoms regarding their oral environment, things like tongue depressions on the sides of the tongue that are giving us clues. We sometimes find that a temporomandibular disorder patient that's experiencing pain can be a secondary symptom because their airway obstructed, and they're doing some very parafunctional. They're creating a lot of parafunction around the system, which creates pain. But at the end of the day, our goal is to pull the tongue forward and open the airway as much as we possibly can. So when a patient is, on their back or on their side, they're going to have a more patent airway. Again, I know that the best therapeutic remedy for a patient is going to be CPAP. I'm just here to help on the sidelines when a patient cannot tolerate the CPAP. And then when I receive a prescription from a physician, I'm doing my best to help make that physician proud, and also help that patient to be more successful with their airway obstruction issues. if I had to have a crystal ball and in the process of really, or a wish list for the best possible outcomes regarding the use of appliance therapy, I would prefer, and I have collaborated with my local laboratories that and sleep physicians on the benefits of doing titration in lab. The way that would work, I would almost say pre-COVID, because I know a lot of times now we're kind of looking at our models of care a little bit differently. But I certainly would want to fit the patient, teach the patient how the appliance works, have the patient get used to using the appliance, then send the patient back to the sleep physician for a PSG with the appliance, and make sure that the lab understands how to help with the titration protocol. We all know what that picture looks like and how that works. After the the titration protocols are met and the PSG is completed, my hope and outcome would be that we've got an appliance that's working really well, and that's actually creating a lot of success for the patient and lowering the all the parameters, especially AHI and RDI. So in my journey, just figuring out some things and learning about what others have found, there's research that really gives us compelling information around the benefits of doing titration during a PSG. And in this study, with 23 patients, not everybody was successful, but at the end of the day, after adjusting the appliances on average 2.7 millimeters, we saw a significant element of success built into the lab titration, and moving from 65 to 95, in my estimation, is a very good success range. Let me just say that as we look at the data and get closer to where the success story, how it was defined, we had three in this study. We had three ways of defining success. One was an AHI that was up less than 10 or up to 10, and then these were all mild to moderate patients, by the way. The AHI down to 5, and then AHI of 10, and an RDI of 15. Getting into bringing patients down to those ranges, where each of the pie charts that you're looking at define some level of success. I think essentially, I think most of us probably want to see success by definition, an AHI of less than 5. That's not always possible with a sleep apnea appliance. I think most of us have learned through our conversations with dentists helping with oral sleep appliances that, generally speaking, our appliances can get a 50% reduction in AHI for a patient. And if we can get down to 5, I think we can all celebrate. But we're certainly more likely to get down to 5, at least 73.9% of the time, if we can titrate, and we can do that well together. And I think that motto, better together, always resonates for me. So I want you to remember the 73.9 as we kind of come into another conversation, and this is what has evolved for me. I think when I think about this topic, I start to begin, by the way, the conclusion of the study was that the protocol helped to significantly increase success rates between 17 and 30%. I think that's worth noting. What I was going to say is a lot of times there's a lot of misunderstanding in how these appliances are actually titrated properly. I think when there's good communication between the different disciplines, especially between the technologist and the dentist in this case, we're gonna get better results. But a lot of the studies that are out there, as this points, as I'm pointing out here, is most of the studies do not really take into account adjustment or titration. I think the other conversation for all of us, especially as we look at how we're helping each other, is how much more significant and is the HSAT going to be, and how are we going to figure out together how to work on getting our data points in a place where a patient, at the end of the day, the patient's more successful. I know that right now there's a lot of conversation about whether dentistry should be involved with home sleep apnea testing. I think just, as I look at our philosophy here in our practice, and I'm not speaking on behalf of any other aspects of the different schools of thinking on this, what we think about when we think about titration is we think about the ability to certainly make our physicians proud if we can, but not all sleep apnea appliances that we're using are going to be successful for all of our patients. But when they are successful, it's usually because we've done a little bit of titrating, and the way we titrate using a home sleep apnea testing device is most often with oximetry, but I will have conversations with some of the sleep physicians that I work with, and if they feel it's appropriate, then we'll use a home sleep apnea testing device. But then the way the way we have developed relationships in our practice with other sleep physicians is we'll say, we've got this in the right ballpark. This appliance is working. As far as I can see, we've got some good results. I'd like you to certify the results. I'd like you to retest the patient, and if they can get the patient into a lab, I'd much prefer that, or most often retest the patient with their own home sleep apnea testing devices. So I belong to a study club that primarily involves dentists, and one of the study club members came up with this statement. He said that with CPAP, we start with efficacy, and then we chase compliance. With oral appliance therapy, we start with compliance and chase efficacy, and that got me very curious. I wanted to know more about that. So what I figured out is that there have been some articles on looking at issues relating to time and compliance, and one group came up with the Sutherland group, as I call it here, came up with this concept of SARA index. And what I learned as I read through this study is that at the end of the day, with the different research that's been done and some of the study designs that have been implemented, that the mandibular advancement device is certainly less efficacious. The level of efficacy with the mandibular advancement device is not as high as we would expect, and we know that the CPAP device is going to be our gold standard, and is going to be absolutely more efficacious. But interesting, part of the study that I thought got me curious as well was that compliance isn't always at the top of the food chain for a CPAP user. I think compliance is the biggest challenge, and it made me think, well, okay, if compliance for CPAP is going to be a challenge, and what I'm thinking about when I think about compliance is if a patient's not wearing a CPAP for more than 4 hours, I think we all know that the patient probably doesn't benefit as greatly as if they're wearing it all night, or at least for more than 4 hours. The oral appliance tends to get greater compliance on the side of wearing, but we know that it's not as efficacious. The efficacy is not as great or efficacious. So, you know, again, it's interesting to see it, as we compare and contrast, what if, the question around what if, and say, for example here, that almost 74% of the time we can be very successful with the appliance after titration. But if we're also able to get greater compliance, you know, there's certainly a good conversation around the role of a sleep apnea appliance in the success of a patient. So one of my conclusions is that the titration of mandibular appliance plus the component of our success with compliance can equal complementary, can be a complementary outcome, you know, and be an alternative to CPAP when necessary. And again, it's looking at that real important piece of the equation, which I think we all think about every day in our practices, and that's our patient and how our patient will do, and they have lives to live. They have stresses in their lives. They've been you know, challenged as we have all been with this new time and place in regard to the world of a pandemic. But it's always nice to know that we're all looking at the patient at the center of the equation here, and we're trying to figure out what's the best for them. So, you know, I think if I had to take out a crystal ball and really think about the future and be part of this conversation with all of you and all of the disciplines around sleep medicine, I'd really be thinking a lot about combination therapy. And, you know, I don't know that we really do think about this a lot as we're collaborating together. And what does that mean? And what outcomes can we achieve? And you know, if we can titrate an appliance to the best of our ability and use science to measure that titration when a patient needs an appliance, or we can understand that a CPAP is our gold standard and is going to be certainly most efficacious in the success of our patients, but might not wear that mask for 4 hours every night. You know, we need to look at that. And I think what I really think about here, and this is the golden opportunity in my estimation, is, you know, maybe we need to think about crossover studies and really bringing a lot of the hope that a patient has for overcoming, or at least living with sleep apnea, to you know, where can we get, where can we combine our ways of helping a patient so that their outcome can be well-being and being healthier as we look at the comorbidities associated with you know, someone who has a sleep disturbed breathing problem or sleep apnea. So, you know, there are studies, but again, they're not up to date, of looking at both you know, combination of therapy, and I think, you know, we can see that there's increased success outcomes. I think, again, the best part of this process is starting to think about what can we do in the future. What studies can we institute ahead, you know, in the next few years, and begin to place some emphasis on the ability to understand maybe the possibility that we could have a look at the way this combination therapy might present itself, and how, you know, how we could organize together some studies around, even as we look at this diagram ahead of us, a study that might just look at wearing the CPAP and the mandibular advancement device together. Remembering too that when I often want to help a physician who's working with a CPAP patient before they go into a full, or leave the CPAP on the sidelines, I want to be able to help a physician maybe consider an oral appliance so that they can turn down the pressure and still use a CPAP. So that's another real benefit as we look at advancing the mandible. You don't have to advance it significantly so the patient doesn't end up having painful and discomfort side effects, and you can still get the patient to consider using their CPAP maybe at a lower pressure rating, so that can be a helpful element to this story as well. But anyway, there could be a study for each of those arrows, and that might be something to challenge our community to think about. And why not be thinking in terms of these kind of concepts? I think the other thing that challenges all of us is, reimbursement and insurance companies and costs. I think that for the most part, if we can get some data and show that there's real significance to combination therapy, I think that makes sense. As we get back to the screening that we do as dentists to get involved with just referrals to our sleep physicians when we see problems, we also know that early on we can be advocates for patients in regard to especially the younger population, managing growth and paying a lot of attention to airway mechanics. Earlier on in today's session, we heard a little bit of talk about orthodontics. The orthodontic community has definitely upped their game a little bit in regard to growth and development strategies, and a lot of orthodontists are starting to really take sleep medicine very seriously. And it's nice to have a community where we're starting to really pay attention for our patients, but also, become part of the, the preventative focus, so that today's young person who's developing and has facial disharmony could be tomorrow's sleep patient. And if we can stay ahead of the curve a little bit and be agents for and advocates for airway mechanics, I think that's the challenge that dentistry has as part of the team, and the team that's helping a patient. I think adult care, we're doing orthodontics. We are expanding maxillary arches. As a maxillary arch is expanded, sometimes a patient who is having a lot of problems with airway and breathing through their nose become much better at that, and in most cases we'll work together with ENTs, but also orthodontics to do some orthodontic care. That nowadays we can use the same kind of devices that we replace teeth with, called implants, and we can actually have an impact and be able to move a maxillary arch, expand it in such a way that it gives patients a much better functional way to breathe. And as we heard earlier today too, and I'm impressed with all the speakers that we've had. I've really enjoyed the learning. I'm a learner. I'm always inspired by all the different disciplines that are coming to the table. But we know that when I look at a young patient, I look down their throat and I see big tonsils, I'm going to refer them to an ENT specialist for a consultation. I might ask them in advance to the mom or the dad. I might ask if their son or daughter are having any trouble breathing and sleeping at night, or even having trouble with school. And most often, I'm going to see wear and tear on their primary dentitions too, because a lot of times when we see wear on the teeth, we know that something is going on mechanically that's causing a patient to want to move their mandible forward, open up their airway, pull their tongue forward. They're doing this all to, to the detriment sometimes of their teeth. This is my son, JP, when he was in high school, had a lot of trouble with learning, especially between his sophomore and junior year. And this is when I began my journey in understanding that sleep medicine is a very significant part of our health matrix. And I referred him to a sleep physician, and he had a sleep study, and then had his tonsils out. He had adenoid and tonsillectomy. And fortunately, he was very successful with that, and he is on to LA now and working in Hollywood. I ultimately think that we are very lucky to have each other and being able to provide care to help our patients, and being an organization like we are, the Maryland Sleep Society, and holding a session like this and being able to learn together, it makes us all better together. And I'm really grateful for the leadership of the Maryland Sleep Society, the board of directors, all those who have been behind the scenes and bringing this workshop together, and Sophie Pumphrey, who's in North Carolina, from MedChi, our executive administrator, has been very hands-on and very helpful. So thank you very much. And lastly, I know that some of us have probably read this book, but I think James Nestor has really put a good compilation of information together, and his book on Breathe is just it's pretty awesome. So I thank you very much. I want to be able to answer any questions and continue to be part of this conversation, and looking forward to the rest of our session tomorrow. Thank you very much.
Thank you. I think, I'll turn mine on and turn Catherine's off here for a second. Okay. Couple of questions, but one comment first. Dr. Mintz would like to share excellent presentation, and he wanted to make sure that everybody's reminded that many sleep physicians are under the assumption that oral devices for OSA are not a covered medical expense. And he says that 95% of medical insurance companies in Maryland and DC cover oral appliances, even Medicare and the VA. So good to know. And Dr. Buki had a couple of questions. First, she wants to know how many of your patients have an embedded compliance tracker?
So I'm not as familiar with embedded compliance trackers, but there are sleep appliance companies that do make them. And again, that is a very important question, because really, how do we get hard data on compliance if we send our patients home with the appliances without compliance devices? It's much easier with a CPAP machine. And so if we were wearing a CPAP machine and had an oral appliance in, and we were benefiting from both devices, we'd certainly know where we are. So I can't really say that I have a good amount of information on that. And I honestly think that with oral sleep appliances, or sleep apnea appliances, the devices are not, we have them out there, but there's not a lot of devices that are being monitored.
Okay. And the next question from Dr. Buki is, can you talk about the importance of using a morning repositioner device and exercises?
Wow, great question. So why do we do that? Why do we have a morning repositioning device? It's really a lot about the jaw being advanced forward for an extended period of time, usually 7 or 8 hours. And there's going to be some fluid buildup in the back of the jaw joint. We call it the retrodiscal space. And that fluid buildup, if it's not handled well, if a patient just clamps together quickly after they've worn the appliance, they can hurt the posterior posterior elements and create a discitis. And so the mandibular repositioning device is or the device that we wear to help reposition in the morning really prevents us from creating harm and more pain in that space. So good question and very important part of the equation.
And last but not least, thank you for that answer. Victoria Marshall would like to say we are definitely better together. Thank you.
Oh, good. It's always a pleasure to be with an organization like this, with all the different disciplines and the people that serve, technologists, psychologists, pulmonary, cardiology, neurology. I'm learning a lot too as a dentist, being part of this great team of people, and I'm thrilled to be able to be with you this afternoon and hopefully bring you down for a soft landing into the weekend, and then look forward to tomorrow's session.
Okay, thank you very much.
Awesome. Thank you.
Well, folks, Dennis, thank you very much for that talk. I really enjoyed the videos. I think we've had a really great day today. I want to thank our attendees for sticking with us today. We have gone through 6 hours of lecture. Thank you to all of those who've attended the virtual break sessions with our vendors and our sponsors. What I would ask is that we have 3 of our sponsors are using Zoom. 2 of our sponsors are using Microsoft Teams. If you have a Windows 10 on your PC, it should be no problem to access the meetings on Teams. If you're using a Mac, you can get Microsoft Teams for Mac, and I've been able to do that on my device. So please consider doing that. We will be reconvening tomorrow morning at 8 o'clock. And the conference will be going to approximately 1 p.m. There will be a break for vendor time around 10:30 in the morning, and we have 4 lectures tomorrow. So we look forward to having you back tomorrow. One last thing that I received from a colleague I'll share this with you. I've not had a chance to look at this document, but the AHRQ, which does healthcare research for quality, which is used by the federal government in establishing some guidance, has a statement out on CPAP. If we can find a link to that site, we can share that so that you can find it readily. I think my colleague had some concerns about what she was reading and thought it might be best for our community to take a look and see if maybe our community needs to offer some feedback. If there are no further questions, I'm going to say that I thank you all for attending, and we will convene, not probably, but we'll convene tomorrow morning. But I think I can probably give you a few minutes back and let you start your weekend a little bit early. Thank you.